Good afternoon. Good afternoon to everybody. Today we deal with the autonomic function tests. We have earlier dealt with the autonomic nervous system, which controls the activity and functions of the visceral parts of the body. Now, today we deal with the autonomic function tests. Autonomic nervous system includes both the sympathetic and parasympathetic system. Now, these tests are useful because the parasympathetic and sympathetic neurons are affected in metabolic diseases like obesity, diabetes, hypertension, heart diseases, hyper and hypothyroidism, and hyperlipidemia, etc. So, the assessment of sympathetic and parasympathetic functions by the autonomic function tests is now a part of the clinical management. That's why there is a lot of interest and attention now paid to the autonomic function tests. There are a variety of autonomic function tests which could be put into several categories, out of which the first category, tests for the cardiovascular autonomic functions. This has a lot of tests. Then come the pseudomotor functions. Pseudomotor function assessments will give more specifically the sympathetic function testing procedures. Vasomotor tests in sympathetic system more. Tests for pupillary function, bladder functions, and others are also there. Now, first we deal with several of these tests in the cardiovascular system's function. So, heart rate response to standing, heart rate response to passive tilting, standing to lying ratio in the heart rate, then heart rate response to deep breathing. Deep breathing encourages the parasympathetic nervous system's activity. And then BP response to standing, baroreceptor reflex sensitivity, a BRS assessment, norepinephrine spillage technique, again, mainly sympathetic function, Valsalva ratio. Valsalva ratio is also essentially for the parasympathetic nervous system testing. Blood pressure response to sustained hand grip. This is an important sympathetic system function test. Cold pressure or cold pressor test is considered to be a very important sympathetic function test. Then under the pseudomotor function testing, you have something called GSR, mostly it's called GSR, or galvanic skin resistance or response. The same thing also can be termed as the sympathetic skin response. Now, here, when we simply say galvanic skin resistance, it essentially talks about, it shows about the sympathetic tone, existing sympathetic tone. When we say response, then there is a stimulus applied, and the response to that in terms of the pseudomotor function is assessed. Thermoregulatory sweat test, again, you can say, when we say pseudomotor is essentially referring to sweat. Here also, the sweat formation plays the role. Quantitative pseudomotor axon reflex test for locally testing the sympathetic activity. Test for vasomotor function using laser Doppler velocimetry for the blood flow measurements, and cold pressor test, which we also mentioned under the CVS. Then there are pupillary function tests, cocaine test, and adrenaline test. These are related to the autonomic function. Then bladder function, cystometrogram is done. Apart from this, the heart rate variability analysis, particularly the spectral analysis, is quite vast, and we deal with that part in the next lecture on autonomic function tests. So first, the tests for a series autonomic function are here. First of them, heart rate response to standing. As from the supine position to standing, that is the procedure done. And then the changes are seen, particularly in terms of the heart rate. So when the person stands from the supine position, heart rate increases immediately. And that goes on occurring about 10 to 20 beats. Then gradually it may slow down. So during this increasing heart rate phase, we select the 15th beat because usually the maximum increase reaches by the 15th beat. And then gradually slows down, and then a stable state is reached by about 30th beat. So first there is an increase, and then there is a followed by a slowdown. So that takes about 30 beats. Now ratio of RR interval corresponding to the 30th and 15th beat is the 30:15 ratio. This is the ratio that is calculated. So here we'll see what is going on about this. This ratio is essentially a is a measure of parasympathetic system. There is a bradycardia at 30th beat, and this bradycardia would depend upon the decreased activity of the sympathetic nervous system and also the increase in the parasympathetic nervous system activities. So here the ratio is something like 1.15 to 1.12 at the age between 21 and 30 years. Then 1.12 to 1.10, 1.1 at 31 to 40 years is about the normal. Ratio decreases with age. Now, when we see this figure is decreasing with age, this figure is decreasing with age. So that essentially says the parasympathetic activity is reduced. Then heart rate response to passive tilting. Now, in the earlier test, the person is made to stand from the supine to standing position. That will take a little time, and that time taken by the individual may vary from one to another subject. So here, a tilt table is used. So this horizontal surface of the table can be tilted to near vertical position, and so during the horizontal position of the top of the table, the subject is fixed to the table so that when he is tilted, he is still sticking up with the table. He will not fall down. Instead, he will be passively coming into a head-up position by about 60 to 80 degrees. 90 degrees is vertical, and it will be less than vertical position. So usually about 60 to 80 degrees tilt is brought about by the tilt table when it is tilted fully. So in this case, variation in time while voluntary standing, that is avoided here. So here the table can be tilted quickly, and the time taken can be same in all the at every time that is repeated. Then about 30% of venous blood is pooled in the lower limbs when suddenly the person is attaining a near vertical position, that too passively, legs hanging down, then naturally there is a venous pooling, venous blood pooling by about 30% of the venous blood is pooled in the lower limbs. So that means cardiac filling is reduced and the stroke volume is also reduced because of this. So naturally cardiac output will be decreased. So that will reflexly, that will also cause the BP to be decreased, which means heart rate is increased reflexly. And this increase in heart rate is mainly by decreasing the parasympathetic activity. And also, little later, the increase in heart rate is because of the sympathetic activity. So here you see parasympathetic activity being decreased and sympathetic activity is increased. Now, then coming to the test, saying standing to lying ratio. Earlier we were shifting from supine to standing. Now it is the reverse of it. From the standing position, the subject is made to lie down. So that ratio of the heart rate is the one which is assessed in this change. So standing to lying posture is attained. And when it is done, actually venous return will be better. In the lying position, the venous return will be improving. So it will increase. So that reflexly, say, through an increase in the BP first, and that in turn reflexly will produce bradycardia. Heart rate, as indicated from the RR interval, is continuously recorded by the ECG. And for this to check, usually the ECG is taken and that the RR intervals are the ones which are analyzed, or the heart rate can be derived from the RR intervals of the ECG. Longest RR interval in standing to the shortest RR interval in lying is calculated, and that gives the standing to lying ratio of the heart rate. Now, if the ratio is little less than 1, that's, or anything less than 1, that is abnormal. So it should be bigger than 1 to be considered normal. Now we will see now heart rate response to deep breathing, because this will increase the sinus arrhythmia, and the sinus arrhythmia is because of variations in the heart rate with respiration, and that is mediated through the sinus node, which is the pacemaker. And what happens in the rhythm, you can see in this tachogram, and here is the respiration graph. Inspiration is downwards and expiration is upwards. So this is the expiration, this is the inspiration. Expiration and inspiration. So that's what is labeled here also, you can see. Now you can see during the expiration, the heart rate is coming down. And during inspiration, the heart rate is going up. This is called cardio-tachogram. It shows how fast the heart is beating and what are the changes in that heart rate. So you can see the heart rate is decreased, increased, decreased, increased. So decreases during the expiration, expiratory phase, and during inspiratory phase, you have the increase in the heart rate. And that change is called arrhythmia. It's called sinus arrhythmia because it is produced through the sinus or SA node, and the SA node is innervated with by the vagus, which is parasympathetic, and during the resting condition, vagal tone is the reason for the sinus arrhythmia. And this vagal tone, if it is reduced, arrhythmia will also be reduced. So this is mediated via parasympathetic nervous system. In this, we'll come to the arrhythmia-related testings afterwards. But this is also deep breathing is one of the things to do with the sinus arrhythmia, because deep breathing will cause the increase in the variability in the sinus arrhythmia. So this is mediated by the parasympathetic or vagal tone. Then, so assess the parasympathetic activity is the target. So deep breathing difference is what is calculated. And this difference is difference between the maximum and minimum heart rate during deep breathing. In this, there is a certain rate. You can say this is 15 seconds. So there are 3 respiratory cycles. So 5 seconds is 1 respiratory cycle, which means the respiratory rate is about 12. Okay. Now, in deep breathing, generally we use 6 breaths per minute. Okay. Now, when the person is breathing deeply and slowly, then the heart rate decreases, number one. Also, the variability increases. So, when you say difference between the maximum and minimum heart rate during the deep breathing, you are essentially looking at the heart rate variability. And sinus arrhythmia is more prominent in the younger people than the older subjects. So naturally, if you happen to check the deep breathing difference of the heart rate, in my case, it will be less. The difference will be less, but in the younger people, there will be much more. Sinus arrhythmia is more prominent. Deep and slow breathing, deep inhalation for 5 seconds, exhalation for 5 seconds. That makes 10 seconds for 1 breathing cycle. And so that makes 6 breathing cycles per 1 minute. 6 cycles of breathing per 1 minute is performed. And it must be deep as well as slow. Not just slow, but it also has to be deep. Then you can see how much is the difference achieved. Usually in the younger age, it is more. As the age is increasing, you can see the beats per minute of the heart is decreasing. That is, this is the difference between the maximum and the minimum breathing rate. So, maximum and minimum heart rate which is achieved during the deep breathing. So, another ratio is expiration to inspiration ratio. That means you perform the respiratory cycles at the 6 per minute. Then you see ratio of longest RR interval in expiration and to the shortest RR interval in inspiration. Now, when we say RR interval is longest, that means slow breathing. That's what happens in expiration. Shortest RR interval means fast heart rate. That's what will happen in the inspiration. So, you look at the ratio of the longest RR interval in the expiration to the shortest RR interval in the inspiration. This is what is called as EI ratio. Earlier, we simply said maximum and minimum of the heart rates. So here is about, in the young people, is about 1.2. This is very close to what we have seen earlier, because the respiratory cycles, the respiratory rate is similarly slow as in the deep breathing test. Now here, lower heart rate has longer RR interval. This way I have already explained what is happening to the RR interval in the expiration or the inspiration. So here, if it is the air ratio values, here also you can see, along with the age, the ratio, E to I ratio is also decreased. So at this age, it is quite small compared to what it is about when the person is about 16 to 20 years. Now, BP response to standing. Now, so far you are talking about the essentially heart rate earlier. Now we have come to the assessment of the function through recording BP change. So changes in the blood pressure in standing, this is essentially for the sympathetic. Because as far as the blood vessels vasculature is concerned, only sympathetic innervation is present. That increase or decreases the diameter of the blood vessels. Then heart, of course, receives both sympathetic and parasympathetic innervation. Now, immediately on standing from the supine position, BP slightly falls, and through baroreceptor mechanism, then it recovers to normal within about 15 seconds. Now here, you'll see if the systolic blood pressure, which may go up something like 20 millimeters or more, diastolic blood pressure by 10 millimeters or more. This is the difference between the before and after stages. Now, if the fall, sustained fall in the BP is at this rate or more than this rate, then you call it as orthostatic hypotension. Okay, so this fall should be as little as possible for the subject not to be unconscious. Then baroreceptor reflex sensitivity assessment, or BRS, baroreceptor reflex sensitivity. Now, this is an autonomic reactivity again, that means both sympathetic and parasympathetic. To various stimuli, orthostatic challenge, BP affecting to drugs. Here, essentially, we are dealing with the blood pressure because baroreceptors are concerned with regulating the blood pressure. So you can change the blood pressure through orthostatic challenge or through drugs which may affect the blood pressure, increase or decrease. So we'll see how the BP is changed to know about the BRS or the sensitivity of the baroreflex. So baroreceptor reflex sensitivity is the measure for expressing the vigor of the baroreceptor reflex function. How strongly the baroreceptor reflex is working. Now, for this reflex, you have sympathetic and parasympathetic. So you can use it as a good marker for assessing both these systems. And baroreceptor reflex sensitivity is defined as the change in interbeat interval in milliseconds per unit increase in the BP by 1 millimeter change. So if the blood pressure is changed by 1 millimeter, how much is the change in the interbeat interval? Now remember here, this word change means there is a duration for this one interval and another interval. And there could be a difference between them. Now, that difference is the change. So, that's what is So here, the interbeat interval is essentially the RR interval. So here you see how much is the interval change if you give a challenge. Then let us say the interbeat interval increased, that means changed by 100 milliseconds when a particular challenge is given. So rise in BP was actually 10 millimeters mercury. So when 10 millimeter mercury was increased, BP was increased by 10 millimeters mercury, then the IBI interval increased by 100 milliseconds. Or if you put per unit 1 millimeter, then it is 100 divided by 10. That will give you 10 milliseconds per millimeter mercury pressure. This is the unit pressure. This is the change in the IBI or interbeat interval. So this is the unit for measurement of the reflex sensitivity. Now, BRS is expressed as milliseconds per millimeter per mercury. Normal is about 20 to 25 milliseconds. Then if the BRS is less than 20 milliseconds, serious health is should be considered poor. Then if it is even less than 15 milliseconds, that means serious is cardiovascular system is at risk. Here it is just poor health, but it is there is a severe risk here. Now, if the BRS is measured as 25 milliseconds per 1 millimeters of mercury change, then this is considered enhanced autonomic tone and improved cardiovascular health. So if it is more than this, so 25 milliseconds, then it is considered to be a better health. This is about poor health. This is really serious health at risk. And if you want to measure the sympathetic activity at a given spot area, then this is a good, norepinephrine spillage technique. What we do is the norepinephrine levels in the blood are measured, but first in the supine position. Now, after standing for about 5 minutes, then the norepinephrine levels in the blood is measured again at the end of the 5 minutes. So standing position should increase the sympathetic stimulation, and hence these levels should be increased at the end of standing. So difference in the blood level of norepinephrine, that shows the alteration in the sympathetic activity, which is increased. Now, how much is increased will show how good is the response. Valsalva ratio. So here, what you do is a maneuver called Valsalva maneuver. The parasympathetic is afferent and efferent both. Sympathetic is only a part of the efferent system in producing this Valsalva maneuver. So essentially, this is for assessing the parasympathetic than the sympathetic function. Now, in the procedure, what the subject is asked to do is close both the nostrils tightly and mouth also. Into the mouth, there is a tube put, and that tube on the other end is connected to the sphygmomanometer. So the person with nostrils closed will blow now into the sphygmomanometer through a tube and maintain a pressure of 40 millimeters of mercury pressure for about 50 seconds. Now, then measured heart rates and BP are measured continuously. So Valsalva maneuver has 4 phases. One is rise, maintenance, release of strain, and then completely now at rest. So there are 4 phases. Phase 1, onset of strain, the strain being increased, or he is blowing into the tube. then BP is transiently increased, lasting for a few seconds. This is because the thoracic pressure, intrathoracic pressure is increased. Heart rates may not change much. This is also a transient increase. Phase 2. In the phase 2, the straining is maintained at 40 millimeters already now. As a straight line, you can say, if there is a graph. In the early part, venous return decreases naturally because everything is pressed on the great veins. Venous return is reduced, so the filling of the heart is hampered. Cardiac output is reduced. Blood pressure is reduced, and then this persists for about 4 seconds initially. Then the BP returns towards normal due to sympathetic vasoconstriction. Then here, steady increase in the heart rate is due to the vagal parasympathetic withdrawal initially, and then followed by sympathetic activation. That means both are occurring. One is the withdrawal of parasympathetic activity gradually, and the activation of sympathetic activity. Phase 3, that means during the fall of this straining. The phase following release of strain, transient decrease in the blood pressure for a few seconds. Then caused by mechanical, this is because displacement of blood happens to the pulmonary vascular blood. Earlier, it was hampered because intrathoracic pressure was increased. Now, when this intrathoracic pressure was reduced, then the blood starts entering into the pulmonary vascular space. So here also there is nothing much change about the heart rate. So phase 4. Now at the end of the release of the strain, release is continued. So here within about 15-20 seconds after the release of the strain, it happens. The changes occur. It lasts for about 1 minute or more. Blood pressure slowly increases. Heart rate proportionally decreases through reflex. So here heart rate is decreased. In the phase 2 earlier, heart rate was increasing. Serious changes occur due to increase in the venous return stroke volume and cardiac output, as we have shown earlier. Valsalva ratio. Now, what are the various changes? One is increase in the heart rate and decrease in the heart rate. Now happening in the phase 2 and phase 4. So here, this is in the phase 4, it is the decrease in the heart rate. So RR intervals are long. And here, when the heart rate is increased, it is short. So use the longest RR interval during phase 4 divided by the shortest RR interval during phase 2 and calculate the percentage. Or if you use the same thing as it is, you'll get a single number. And if you multiply by 100, then you get a percentage. So Valsalva ratio is the ratio between the longest RR interval during the phase 4 and the shortest RR interval during the phase 2. Here you find the ratio is again high in the younger people. In the older people, it is reduced. And you can see the reduction in the Valsalva ratio. This also shows the decrease in the cardiac health. So Valsalva ratio more than 1.45 is normal. Ratio between 1.2 to 1.45. Less than 1.45, but higher than 1.2 is borderline, still taken for granted. Then if it is less than 1.2, it is abnormal. So failure of heart rate to increase during strain is showing sympathetic dysfunction. Similarly, failure of heart rate to slow down after strain is because of the parasympathetic dysfunction. So if these things, this increase or decrease in the heart rates do not occur, they indicate the corresponding dysfunction in the autonomic nervous system. Abnormal CVS response in Valsalva maneuver, but normal response to cold press heart test. That exactly shows that baroreceptor reflects abnormality rather than anything else. And this happens in the diabetic neuropathy. So if cold pressor test is normal, then receptor reflex is the one which is normal. And this can happen in the diabetic peripheral neuropathy. BP response to sustained hand grip is a very clearly a sympathetic stimulus or stimulus that enhances the sympathetic activity. Hand grip dynamometer is a exertion. You hold the dynamometer, press, try to press, which is the isometric contraction. So maximum resistance is first generated and measured through the maximum voluntary effort, which is a isometric contraction. Now, of this maximum voluntary exertion, 30% is calculated. 30% of the maximum contraction is maintained for about 5 minutes. So you cannot maintain 100% contraction because it is very difficult to sustain for such a long period. So 30% is chosen for maintaining this contraction for 5 minutes. Heart rate and BP are recorded before and after hand grip. Now, what is producing or responsible for this change is central motor commands for the isometric exercise causing the reflex response, where the heart rates are increased. Blood pressure also will increase. Then normal response, diastolic blood pressure is increased. If it is more than by more than about 15 millimeters, and heart rate is increased by about 30%. So rise in BP because of the sympathetic activity increase. Rise in heart rate is due to the fall in the parasympathetic activity. And response is not dependent on the age, and hand grip test is a very good sympathetic response test. Then cold pressor test. Cold pressor test is also another one of the best sympathetic response tests. Here, this cold pressor test is also called cold pressure test. Most commonly, the word cold pressor is used. So what is done is in this is the hands, preferably, or feet, they are immersed in ice cold, about 4 degrees centigrade temperature water for about 30 to 60 seconds. Some prefer to use a duration of 60 to 90 seconds also. Now, here when you apply this ice cold water, the stimulus is stimulating the cold receptors and the pain receptors. So, because we call this cold pressors, some would like to prefer to avoid this stimulation of pain receptors. So what can be done is raise the temperature to some extent, maybe about 10 degrees centigrade. But commonly 4 degrees centigrade is traditionally used, which causes cold stimulation as well as pain stimulation. Somatic afferents carry the sensation, and the efferent is essentially the sympathetic. BP recorded before and immediately after the immersion. Systolic blood pressure goes by 20 millimeters of mercury. Diastolic blood pressure increases by about 10 millimeters of mercury. And this is one of the best sympathetic response tests. Pseudomotor function, this refers to sweat production, sweat. So pseudomotor nerves causing sweat production from the sweat glands. So, and these tests are checked for assessing the pseudomotor function. So this depends upon sympathetic and cholinergic endings on the sweat glands. Sweat gland and sweat production is the final part. And the part of the autonomic nervous system is sympathetic, but it is cholinergic. Elsewhere, commonly sympathetic nervous system has norepinephrine as the postganglionic terminal neurotransmitter. Here it is the acetylcholine which is the neurotransmitter. So for this, one test is galvanic skin resistance and response. As I said in the beginning, just at the resting stage, you can take galvanic skin resistance, measure the GSR, and if you want to apply a stimulus to produce a response, then you call galvanic skin response. So in both cases, it is GSR. It is also can be called a sympathetic skin response, a very reliable sympathetic assessment test for and more easy also, because you simply apply two electrodes through which a small current is passed. Small current is passed, and the resistance to that electrical flow or electrical current is measured between 2 points of the skin, usually hands, for example. So, to assess the peripheral sympathetic chronologic pseudomotor fibers is the aim. GSR is the most commonly used as an indicator for sympathetic tone and vigor of the sympathetic response as well. So, for this, what is changing the resistance? Wetness of the skin. And that is because the sweat formation causes electrical resistance of the skin to decrease. That may be obvious. If there is a wetness, resistance to the flow of the current is less. So electrical current is flow is more. So here resistance is what is measured generally. Then dryness of the skin increases the resistance. Wetness will cause the decrease in the resistance. And this means, wetness means sympathetic activity is more, and dryness is referring to less sympathetic activity. So here, sweat alters the dryness and wetness, and through this, the resistance is altering, and you are measuring galvanic skin resistance if there is no stimulus from outside, and if there is stimulus to increase the activity of the sympathetic nervous system, like a loud sound, or the person may be asked to do the dynamometer, hand with dynamometer, and the person may even be asked for mental arithmetics, etc., which are all likely to increase the sympathetic activities. So here, measure the galvanic electrical resistance in skin while passing a suitable electrical current, and response changes to the stimuli which increase sympathetic activity. Now, this response is age dependent, seem to be available up to 60 years of age. Then sympathetic skin response is present in both hands and feet. Latency and amplitude particularly is measured. So amplitude in hand is about 1.6 millivolts, and in the feet is 2.1 millivolts for the response. And it is helpful variable to measure in the diabetic and alcohol peripheral neuropathy, progressive autonomic failure. Thermoregulatory sweat test. This is also pseudomotor test. To assess sweating, pseudomotor activity, subject's body temperature is raised by 1 degree centigrade. Expose him to diffuse heat. Use a electrical heater. Area for studying sweating is demarcated, and that demarcated area is applied with the iodide starch or quinine powder, which will change the color when the skin is wet with the sweat. So this will show that there is sweat, and so there is sympathetic activation. Absence of sweating in TST. This shows sympathetic postganglionic lesion. When the body temperature is raised, there must be some sweat. So if that is absent, so sympathetic postganglionic peripheral lesions are expected. Then quantitative pseudomotor axon reflex. Here, you can measure the regional pseudomotor function in a given small area. So you inject acetylcholine and induce sweating intradermal injection is done. Then assess the sweat production rate. So reduce the absence of sweating, postganglionic lesions or pseudomotor fibers to the tested area only. So this is only just a regional, local approach, almost similar to what we have seen in the earlier test. Tests for pupillary function, pupillary dilatation, particularly. You use cocaine test and adrenal test. Now, in the pupil, the adrenergic endings, they cause dilatation. Now, if you give cocaine, dilatation of pupil by instilling 4% of cocaine into both eyes, pupil dilate. Why? Cocaine prevents the reuptake of norepinephrine at the adrenergic endings. So, if there is some adrenergic nerve endings intact, and adrenaline is intact, and noradrenaline is intact, then that increases. And that increases, it causes pupillary dilatation. Pupillary dilatation. So, cocaine causes this increase in prevents the reuptake of the norepinephrine, and so it increases the level of norepinephrine at the nerve endings. So, cause the pupillary dilatation. In harness pupil, there is no such dilatation because of the because there is sympathetic involvement. Sympathetic function is curtailed there. So, if even if you give cocaine, there is no adrenaline, there is damage already to the endings. So, there cannot be any reuptake or no reuptake of the norepinephrine. So, there is nothing like increasing the levels of norepinephrine at the endings. So, there is no dilatation. But then, if you use adrenaline, 1% norepinephrine, then normal pupil dilates. No problem. Yes, because any adrenergic drug will do that. And in harness pupil, also dilate, it causes dilatation. Because here, we said the sympathetic nerve fibers were damaged. So that means denervated. You can say denervation. So there is something called denervation hypersensitivity of the receptors in the tissue, in that particular tissue. So because of that, you will find the pupil, the muscles related to the contraction, constriction, dilatation of the pupil. They are showing a hypersensitivity to the adrenergic stimulation. Cystometrogram is done for assessing the bladder function. So, if the ability is decreased for accommodating urine, that means filling the urinary bladder, that shows dysfunction of autonomic nervous system. Contraction of bladder muscle is poor, then evacuation of the bladder during excretion. The passing of the urine is less or difficult because bladder muscle is not contracting well. It's poor muscle contraction of the bladder muscle. So that is also a dysfunction. Relaxation as well as inability to contract well in two different conditions. Here it is filling, here it is evacuation. Whatever, in whichever case there is a problem, then you can look for ANS dysfunction, autonomic nervous system dysfunction. Here, quickly we'll go through. There are certain autonomic function tests for particularly with sympathetic assessment, preferably. BP response to standing, head up tilt, hold pressure test, isometric hand grip, galvanic skin resistance and response, thermoregulatory sweat tests, tachycardia ratio, Valsalva ratio, norepinephrine spillage test, and then here HRV in that a particular part of the variable, low frequency and the low frequency normalized units. These are for the sympathetic assessment. For parasympathetic assessment, resting heart rate shows vagal tone, 30 to 15 ratio, E to I ratio, Valsalva ratio, bradycardia ratio, baroreceptor sensitivity, standing to lying ratio, and high frequency normalized units of the heart rate variability. These are good for the parasympathetic assessment. Thank you very much. Tomorrow, we will deal with the heart rate variability, which is a very important testing procedure. And in that testing procedure, there are a lot of parameters that are derived from the ECG on heart rate or the RR intervals or the cardiac cycle durations and the variability in the cardiac cycle variation, which comes because of the sinus arrhythmia. Thank you very much.